Selamat pagi dan selamat datang kami ucapkan kepada para hadirin dan tamu undangan terhormat dalam acara pembukaan Dies Natalis ketiga dan presentasi poster program Field Lab semester 5 Fakultas Kedokteran Unika Soegijapranata. Tanpa mengurangi rasa hormat, kami mohon agar telepon seluler dan alat komunikasi lain dapat disetel dalam posisi getar atau silent.
Morning and welcome, ladies and gentlemen, in the opening for the third anniversary station, Fifth Lab Program, 5th semester Unika Soegijapranata of Medicine.
Bapak Ibu hadirin sekalian, senang sekali kita dapat berkumpul di sini baik secara luring maupun daring. Izinkan kami untuk memperkenalkan tamu undangan kita. Yang terhormat, Bapak Robertus Setiawan Aji Nugroho, STM Com IT PhD, selaku Wakil Rektor Unika Soegijapranata. Yang terhormat, Profesor Bandana Seini dari International Expert on Non-Communicable Disease. Dan yang kami hormati, perwakilan dari Puskesmas Ngesrep, Puskesmas Candi Lama, Puskesmas Pegandan, Puskesmas Manyaran, Puskesmas Kagok, Puskesmas Sekaran, Puskesmas Gunung Pati, Puskesmas Rondol, Puskesmas Ngemplak Simongan, dan Puskesmas Pandanaran.
Very happy to see you all gather here, either online or offline. But before, let's introduce you to our guests. First, there is Mr. Robertus Setiawan Aji Nugroho as our Vice Rector, and then our special guest, Professor Bandana Seini from International Expert on Non-Communicable Disease, and the representative from Public Health Center.
Bapak Ibu, izinkan kami untuk membacakan susunan acara hari ini. Akan ada 3 sesi, yaitu pembukaan berupa sambutan, dilanjutkan presentasi dari Profesor Bandana Seini, dan yang terakhir presentasi poster.
Ladies and gentlemen, allow us to read the rundown. There are 3 sessions. First, opening, and then we will have scientific session, and the last one, poster presentation.
Sebelumnya, kami meminta maaf sebesar-besarnya atas keterlambatan kami dalam memulai acara hari ini, dikarenakan ada beberapa kendala teknis.
Ladies and gentlemen, we are very sorry for open the ceremony.
Baik, hadirin sekalian, untuk mengawali acara hari ini, marilah kita berdoa terlebih dahulu. Doa akan dipandu oleh Suster Dini.
Ladies and gentlemen, before we start, let us pray. Prayer will be led by Sister Dini.
Baik, Bapak, Ibu, dan para hadirin, mari kita awali dengan berdoa. Di sini saya akan memimpin secara Katolik, yang lain penyertaan. Dalam nama Bapa dan Putra dan Roh Kudus. Amin. Ya Bapa yang Maha Pengasih, puji dan syukur kami panjatkan kepadamu atas segala rahmat yang Kau berikan kepada kami. Terlebih rahmat kesehatan, sehingga kami boleh berkumpul di tempat ini dengan keadaan yang sehat. Bapa, kami juga mengucap syukur padamu atas penyertaan-Mu dalam pelayanan kami di Fakultas Kedokteran Universitas Soegijapranata. Kiranya ya Bapa, karena pendampingan-Mu kami boleh merayakan ulang tahun yang ketiga ini. Bapa, kami pun juga mohon penyertaan-Mu dalam rangkaian acara ini dari awal, akhir, hingga akhir nanti. Kiranya ya Bapa, acara ini dapat berjalan dengan baik. Kami mohon juga dampingilah mahasiswa kami yang akan mengadakan ujian. Kiranya Engkau sertai mereka, Engkau berikan mereka ketenangan di dalam pikiran maupun hati mereka, agar mereka mampu melaksanakan ujian dengan baik, dan mampu memberikan yang terbaik dari apa yang telah mereka usahakan, yang telah mereka tuangkan dalam pembelajaran mereka. Banyak hal yang ingin kami panjatkan kepadamu ya Bapa, kami percaya Engkau selalu sertai kami. Semua ini kami serahkan kepadamu dengan perantaraan Kristus Tuhan kami. Amin. Dan Bapa dan Putra Kudus. Amin.
Terima kasih Suster Dini. Bapak dan Ibu, marilah kita menyanyikan lagu Indonesia Raya dan himne Unika.
Thank you, Sister Dini. And now we are going to sing Indonesia Raya, Unika.
Hadirin dipersilakan untuk berdiri.
Please everyone stand up.
Indonesia bangsaku, bangsa yang airku, marilah kita bersatu, Indonesia bangsaku. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah hatinya, untuk Indonesia Raya. Indonesia Raya, merdeka, aku negeriku yang kucinta. Indonesia Raya, merdeka, hiduplah Indonesia Raya. Indonesia Raya, merdeka, aku negeriku yang kucinta. Indonesia Raya, merdeka, hiduplah Indonesia Raya.
dipersilakan duduk kembali.
Ladies and gentlemen, you may sit down.
Baik, para hadirin sekalian, selanjutnya kita akan mendengarkan sambutan yang akan disampaikan oleh Dr. John Sinar Silalahi, MSI Med SPB SPPA, selaku Ketua Panitia Acara Dies Natalis ketiga, Fakultas Kedokteran. Untuk Dr. John, kami persilahkan.
In a moment, we will listen to the first welcoming speech from the 3rd anniversary Chairman of Committee. Dr. John Sinar Silalahi, please come on stage.
Terima kasih. Selamat pagi. Good morning, Professor Bandana Saini from University of Sydney. Thank you for joining in this event. Selamat pagi, Pak Aji sebagai Wakil Rektor IIRP yang mewakili Pak Rektor. Selamat pagi, Bapak Ibu yang mewakili dari Puskesmas Kota Semarang. Kami sangat berterima kasih sekali atas bimbingan Bapak Ibu sekalian terhadap anak-anak kami FK Unika yang sudah sangat baik. Selamat pagi Bapak Dekan yang sudah bergabung. Ya, sudah. Ya, selamat pagi Bu Kaprodi, Sekprodi, Bapak Ibu dosen sekalian dan juga adik-adik mahasiswa yang sudah sangat luar biasa. Saya melaporkan sedikit Pak Aji untuk rangkaian Dies Natalis. Ini kebetulan memang hari ini jadwalnya anak-anak kita ini ujian fit lab. Jadi momen ini kami gunakan untuk sekaligus memulai rangkaian Dies Natalis. Jadi rangkaian Dies Natalis nanti ada beberapa kegiatan. Yang pertama kita mulai hari ini opening ceremony-nya dan berikutnya nanti ada lomba Olimpiade Biologi tingkat SMA. Jadi kita akan memperkenalkan FK Unika ini ke SMA se-Indonesia, ya terutama nanti yang DTPK karena keunggulan FK Unika ini adalah DTPK sehingga kita lebih fokuskan ke DTPK untuk saudara-saudara kita yang di daerah-daerah. Kemudian dilanjutkan acara ada nanti seminar herbal di bulan Januari. Kemudian pada tanggal 14 Februari akan ada Misa Dies sekaligus di hari Valentine karena kita juga mengungkapkan kasih ya, kasih terhadap sesama. Kemudian akan ada bakti sosial di sekitar awal Februari. Kita masih mencari tempat di suatu desa nanti di sekitaran Semarang atau Jawa Tengah. Kemudian akan diakhiri di puncak Dies di tanggal 19 Februari, di mana nanti akan diadakan seminar nasional tentang DTPK, dan ada penampilan nanti sedikit dari anak-anak kita sebagai budaya daerah. Itu rangkaian Dies. Untuk FK Unika, saya mau merefleksikan sedikit, kita masih mau masuk ke tahun yang ketiga. Kalau kita melihat dari sisi waktu, masih kalau manusia belum bisa lari, baru belajar lari. Gitu ya. Tetapi dalam 3 tahun ini FK Unika saya kira sudah membuktikan bahwa kita layak dan pantas untuk diperhitungkan. Sekali lagi tentu karena kerjasama semua pihak, dosen, rektorat, dan terutama adik-adik, ini angkatan perintis 2019 yang luar biasa, yang tangguh gitu ya. Saya akan merefleksikan kalau kita mengibaratkan sebagai manusia mungkin agak lambat karena dari lahir, tengkurap, merangkak, baru bisa jalan, baru lari, cukup lama prosesnya. Saya pikir untuk FK Unika bukan seperti bayi manusia, tapi seperti Raja Wali. Raja Wali ini mungkin banyak yang tahu, sangat menarik sekali burung Raja Wali itu. 2-3 bulan sudah mulai belajar terbang. Nah, yang menarik adalah ketika belajar terbang, ternyata justru dijatuhkan oleh induknya. Dari sarangnya yang begitu tinggi, jadi Raja Wali ini sangat tinggalnya di tempat-tempat yang sangat tinggi, di pohon yang tinggi, di gunung-gunung. Tujuannya untuk bisa melihat sasaran mangsa yang jauh di bawah. Dan yang luar biasa, Raja Wali ini memiliki fotoreseptor untuk penglihatan itu 1 juta unit. Manusia cuma 200.000. Jadi jauh lebih tajam. Nah, saya berharap nanti anak-anak kita ini juga harus tajam penglihatannya melihat segala permasalahan kesehatan atau non-kesehatan yang berada di sekitar kita. Jadi harus seperti mata Raja Wali. Itu harapannya satu. Kedua yang menarik tadi, ternyata untuk belajar terbang justru dijatuhkan oleh induknya. Jadi harus siap juga jatuh bangun. Gitu ya. Tapi tidak akan dibiarkan kalian jatuh tergeletak. Ada induknya yang melindungi, ada yang menuntun kalian. Nah, induk Raja Wali itu ternyata ketika melatih anaknya untuk terbang, itu dijatuhkan dari tempat tinggi. Begitu anaknya jatuh, dia akan tancap gas duluan ke bawah untuk memberi punggungnya tempat mendarat si anaknya. Sehingga anak ini tidak mati. Dia mendaratnya di punggungnya dan dia angkat lagi bawa ke atas, ke sarangnya. Itu juga bisa terjadi pada kalian nanti. Percayalah bahwa kita sebagai induk kalian akan tetap mendukung kalian. Yang menarik lagi apa dari Raja Wali? Umur panjang, bisa sampai 120 tahun. Kalah manusia ya. Nah, makanya saya juga menganalogikan FK Unika bukan manusia, tapi sebagai Raja Wali. Raja Wali yang siap terbang. Bisa sampai 120 tahun. Namun yang menarik dalam hidupnya adalah sekitar usia 40 sampai 60 tahun, dia akan mengalami masa susah. Paruhnya sudah kepanjangan, sudah sampai ke lehernya, kukunya sudah tidak tajam lagi, sehingga dia sudah kesulitan untuk mencari makan, memangsa, sudah sangat kesulitan. Sehingga ada masa di dalam hidupnya dia sekitar usia 40-60 tahun, dia akan mengasingkan diri, akan merusak paruhnya. Setelah paruhnya dirusak akan tumbuh paruh yang baru, yang tajam. Dan setelah tumbuh yang baru, yang tajam, dia akan menggerogoti cakar-cakarnya dia yang sudah tua tadi, yang sudah tidak berfungsi, dan juga bulu-bulunya. Sehingga muncul bulu-bulu yang baru dan menjadi petarung baru. Sebagai seorang calon dokter, saya juga mengalami itu. Jatuh bangun, kalian pun pasti akan mengalami itu. Itu bagian dari proses untuk bisa sukses dan menjadi panjang umur seperti Raja Wali tadi, bisa sampai 120 tahun. Jadi, saya berusaha menganalogikan itu kepada kita semua, khususnya adik-adik. Saya berharap FK Unika ini adalah seekor Raja Wali yang siap terbang. Satu lagi yang menarik dari Raja Wali, mungkin masih ada waktu sedikit ya, karena memang menarik sekali. Kita mengalami badai di FK Unika. Kenapa makin pas Raja Wali ini? Dan saya baru dapat tadi malam ininya. Karena saya pikir-pikir apa ya yang cocok dengan FK Unika gitu. Ternyata dapat tadi malam. Di dalam kesulitan habis operasi tengah malam datang ini. Setelah operasi 7 ya kemarin. Raja Wali ini kalau ada badai, dia tidak menghindari badai. Itu luar biasa. Dia akan melawan badai dan dia akan naik ke atas badai ke udara, angin yang lebih tenang sehingga dia bisa terbang tenang di sana. Jadi dia tidak bertahan di dalam badai tapi dia lawan. Kita semua di sini sudah melewati badai itu dan terbukti kita semua Raja Wali yang bisa melewati badai. Terima kasih, selamat pagi.
Terima kasih Dr. John. Sambutan kedua akan disampaikan oleh Dr. Indra Adi Susianto, MSI Med SPOG, selaku Dekan Fakultas Kedokteran Unika Soegijapranata. Kepada Dr. Indra, kami persilakan.
Next one, we will listen to Dr. Indra Adi Susianto, SRD. Dr. Indra, please come on stage.
Thank you, host. Good morning, ladies and gentlemen. Thank you to each and every one of us for being here with us today. We are pleased to be able to welcome to Prof. Saini as a Director, Academic Education, University of Sydney School Pharmacy to our event. and Mr. Ferdinand, Mr. Haji as a Vice Principal of Soegijapranata Catholic University. Thanks a lot for your support. And on the next February, we will have our third medical faculty anniversary. And we are proud to be able to host it from today. We will start on Unika. This wonderful place for us is our heart. And before we get started, I would like to express my sincere appreciation to the organizing committee, Mr. John Sinar, Mr. Perin, and the BMSI guy up there, and all of us here who are generously help us to make this event success. In today's event, we would like to focus on our field lab program competition as a part of our third Dies Natalis that will be held on February. And to all my students, you have been chosen to be the part of our community, to become a good doctor. A good doctor means a doctor with a good heart. And your patient, with your patient, of course, we can unite the energy that we can create to achieve your own goal to become a good doctor. So today, all of you will learn about different initiatives through the event that our declared today. So all of you can join in, share the experience, get hands with others to get the best what we can do for our patient. So this event, I will hope that you can open your mind, open your horizons, so you become more productive and more smart. Well, enjoy today, enjoy the rest of this event, and thank you very much.
Terima kasih, Dr. Indra. Selanjutnya kita akan mendengarkan sambutan dari Wakil Rektor Unika Soegijapranata, Bapak Robertus Setiawan Aji Nugroho, STM Com IT PhD, yang juga sekaligus akan membuka rangkaian acara Dies Natalis ketiga Fakultas Kedokteran. Kepada Pak Robertus, kami persilahkan.
Now we will listen to Mr. Roberto Setiawan Aji Nugroho as our Vice Rector to open the ceremony. Mr. Robertus, please come on stage.
Thank you. The distinguished speaker, Professor Bandani Saini, honorable guest, the Dean and Vice Dean of the Faculty of Medicine, Soegijapranata Catholic University, Head and Secretary of the Medical Study Program, lecturers, staffs, and all students, good morning. I'm Robertus Nugroho, the Vice Rector for Innovation, Research, Publications of SCU. First, I would like to apologize that Rector cannot attend this very important event as he has been scheduled to visit several high schools in Yogyakarta and Magelang today for collaboration programs. Second, on behalf of Rector and all the members of SU, we want to take a great pleasure in congratulating all the members of Faculty of Medicine SU on preparing the auspicious third anniversary celebration. Over the past 3 years, the Faculty of Medicine SU has been providing a strong foundation to nurture the future doctors focused on serving underdeveloped areas in Indonesia. It also provides unique learning environment supported by a very proficient and dedicated lecturers and staffs. Meanwhile, Faculty of Medicine has also made valuable contributions to SU itself. Although it is still very young, only 3 years, but Faculty of Medicine has become one of the most important faculties in the university. Faculty of Medicine has successfully led and put example on how to deal with the COVID-19 pandemic. Soegijapranata Catholic University always supports all the hard work of the faculty. We hope that 2022 becomes the mark of the new success for the faculty, welcoming the new campus in PSB, ready to move in for the next semester. And also, I informed that the development of the second building for the laboratory of the Faculty of Medicine in PSB will be started very soon to provide better environment and facilities. Again, we would like to wish the third anniversary celebration of the Faculty of Medicine a fruitful and memorable event, and all members of the faculty continued success in the future endeavors. Thank you very much. And by this, this event is formally open. Thank you very much.
Terima kasih Pak Robertus atas sambutannya. Nah, sesaat lagi kita akan masuk ke sesi yang kita tunggu-tunggu banget nih.
Sesi ujian ya, Nathan.
Bener banget, tapi sebelumnya kita akan menyaksikan presentasi dari tamu spesial kita, Profesor Bandana Saini, dari International Expert on Non-Communicable Disease.
Ladies
Thank you
and
very
gentlemen.
much. May I share my screen?
Good.
Not yet.
Very good afternoon, Professor Bandana. Thank you for joining us today. Professor, to make sure everything is good, can you hear me clearly, Professor?
I can, thank you.
Okay, Professor, for your information, we will give you around 20 to 30 minutes for the brief overview. But before, it's my pleasure to introduce your expertise in non-communicable disease to our participant. There are around 100 participants in here, consists of various background, physician, lecturer, general practitioner from primary healthcare center in Semarang City, and medical student. It's a big chance to hear from you directly, so we would like to hear more from you regarding to the role of pharmacists in chronic disease management in Australia. Well, ladies and gentlemen, this is Professor Bandana Saini. She has been involved in many projects like screening or case detection, patient self-management, pharmacovigilance, pharmacy education, and community health education program. She is a high-throughput researcher who has led and collaborated in implementing and evaluating several successful pharmacy-based service trials in respiratory and sleep health. Okay, Professor, the time and Zoom is yours.
Thank you so much. I'm just going to share my screen. So let me know if that's working well. Yep.
Okay, Professor, we can see your share screen.
Brilliant. Thank you so much, Terima kasih, for the lovely introduction, and selamat pagi to all of the honored faculty members and students. I'm very privileged to be talking to you. Just a quick disclaimer. My clinical expertise lies in sleep disorders and respiratory health rather than cardiovascular disease and diabetes, which is what I'm going to talk about today. So this is what the University of Sydney currently looks like, with the beautiful jacaranda flowers. And very soon in March, we hope to welcome back all our students, hopefully face-to-face with little impact of COVID, but fingers crossed. So just a quick intro to Australia. It's a geographically very large country of about 7 million kilometers square, but it has a very small population compared to yours, for example, around 26 million. If we look at our public health indicators, for example, if you look at life expectancy, or we look at infant mortality rate, or we look at potentially avoidable deaths, then I guess these indicators are quite strong for Australia. I think some of the key issues with our population are, one, that it's a very, very diverse population. So, for example, we know that about a third of Australians were actually born overseas, and this brings a lot of sociocultural diversity and different kinds of health beliefs. The other big issue, of course, is that we are an aging population. Again, I think that contrasts a little bit with Indonesia. So if you look at this picture here, and Australia is in the orange bars, you'll see that, compared to other Asian countries, about 16% of our population is over 65 years old. So clearly, with such an aging population, that brings a burden of chronic disease or non-communicable diseases. And so our latest data from the Australian Bureau of Statistics shows that about 50%, that's nearly half, of all Australians have at least one of 10 key chronic conditions, and about 20% of Australians will have two or more of those key chronic conditions. We know that 50% of hospital visits are in relation to these chronic conditions, and about 90% of deaths are related to these chronic conditions as well. And I'll quickly show you these chronic conditions in a minute. So if we rank them in order, the biggest burden is posed by coronary heart disease. And then you will see lung cancer, COPD, and you see asthma. So you can understand my interest in looking at respiratory health. And you see type 2 diabetes at position 12. And here are some other disease burdens for Australia in order of rank. So there are many underlying risk factors that probably are common across the world that are causing this high level of disease burden. So we know, for example, again, from our data, that about 63% of Australians had abnormal blood lipids in about 2012. 3.1% have impaired fasting blood glucose levels. About 63% are overweight or obese. And about 34% had high blood pressure. So this was measured in 2014-15. So that's quite a high level of risk exposure. And if you look at individual risk factors and behaviors, then tobacco use contributes 9% to the overall chronic disease burden. High BMI or body mass index, 7%. Alcohol use, 5%. Physical inactivity, 5%. And high blood pressure, about 5%. And in total, all of these factors contribute 31%. So that's quite a high level of risk that's posed by inappropriate behaviors. And clearly, many of these are quite modifiable. So before we go into the role of pharmacists, I very quickly want to summarize the Australian healthcare system. So it's a tiered system, which means that there are very clear demarcations between the primary healthcare system that comprises mainly of general practitioners, community healthcare centers, Aboriginal healthcare centers or Aboriginal medical centers, as well as community pharmacies. And then you have the secondary level of care like outpatient clinics, and the tertiary level of high level intensive specialized care in hospitals. All Australians are subject to paying income tax, and 2% of that tax is called, on your taxable income, is called the Medicare levy. And this actually funds a national universal health coverage system. So what does this health coverage cover? Let's talk about Medicare first. So Medicare will cover, for any Australian resident or citizen, most of the general practitioner's fees. So general practitioners or GPs will bill Medicare directly, so people don't have to pay to see a GP. And about 85% roughly, and this might change depending upon the type of service, 85% of specialist fees. Now, all of these services are listed on a schedule called the Medicare Benefit Schedule. And you have item numbers. So if any healthcare professional delivers a service, they can bill Medicare quoting that item number. Then you also have the Pharmaceutical Benefit Scheme, where any drug that is approved by our Therapeutic Goods Administration is checked for cost effectiveness. And if it is cost effective, it is put on a national formulary called the Pharmaceutical Benefit Scheme. And as part of this benefit scheme, a patient will pay a set co-payment, and the rest of the cost of that medication will be covered by PBS. Now, pharmacies are very highly regulated in Australia. So actually, the markup that is allowed for a wholesaler or a drug manufacturer to charge a pharmacist who's getting these drugs to supply to the public is fixed. The markup that a pharmacist can put on the price of a drug is also fixed. So all across the country, a particular medication or drug will have the exact same cost. And this makes the, livelihood of community pharmacies very competitive. And that's why a lot of them turn to the provision of services, which I will talk about. In terms of Medicare benefit schedule numbers, there's only 1 or 2 item numbers that are listed specifically for pharmacy services. And these include home medicines review, HMR, or residential medication management reviews. So residential aged care is our facilities where people who are older and who can no longer look after their functional needs or activities of daily living can go and enter these facilities. I should also say that hospital coverage is mainly done at the state level, although there's a little bit of capping provided by the federal government. So let's look at community pharmacy now. There are about 5,000 or let's say 6,000 pharmacies in Australia, and they have about 35,000 pharmacists who work in these pharmacies. Pharmacies have to be owned by a pharmacist with a degree, but of course that ownership is private, so it's private infrastructure, and it's a decent sized industry actually. I think the beauty of community pharmacy lies in the fact that they're very accessible. So a regular Australian will see a community pharmacist or visit a pharmacy 18 times a year versus a GP once or twice a year. And although pharmacists' core role is medicine supply, but many pharmacies now do provide an extended range of services that target some of these non-communicable diseases and associated risk factors. So pharmacy services can be defined as actions that are taken within a pharmacy and either by a pharmacist or someone appointed by a pharmacist. And the purpose of these services is really to optimize either the process of care or to improve health outcomes or add to the value of the healthcare to the healthcare system. So value-based care. If I, as a health services expert in pharmacy, in my opinion, we can divide Australian pharmacy health services into 4 quadrants. And one would be, I would call quadrant A, that supported healthcare services. So these are services that the government through Medicare or other schemes actually pays for. And one of the funding mechanisms is that every 5 years, the federal government makes an agreement with the main pharmacy bodies. And in these agreements, they will fund certain clinical services. They will agree to what is the dispensing fee a pharmacist can charge, and they agree on the markups that are allowed for wholesalers and for pharmacists. So these services are supported, and they include HMR, RMMRs, which I'll talk about, needle exchange programs, harm minimization, opioid agonist therapy, vaccinations, and indeed, community pharmacies have played a major role in achieving the 92% vaccination rate that we have in Australia, and dose administration aids, which are like, memory aids for people to help them remember to take their medications. Then I would say there are mixed services. These services have support, but they don't necessarily get funded at the government level. They may be funded by other mechanisms. Then there are entrepreneurial services, which are really services that community pharmacy owners decide to venture on or embark upon to create a competitive advantage for themselves. And of course, we do, for every 5-year agreement, there is monies that is kept aside for research. And so over the last 20 odd years, a lot of research in pharmacy services has been undertaken. So I'm quickly going to showcase these examples for you. So HMR or RMMR, Medication Review Service, it's funded so as to improve the quality use of medicines and to decrease the number of adverse events. Now, I'll show you the process. So a HMR or an RMMR would usually start with the patient seeing a doctor, a GP, and the GP realizing that the patient is on more than 5 medicines, or they've recently had a hospitalization, or they've had a therapy which has a very narrow therapeutic index that they need to monitor. They've just been put on that. So whatever reason, if the patient is eligible, they will then contact either the patient's own community pharmacy or an accredited consultant pharmacist. Now, and they'll pass all the patient's reports, data, medical history, pathology to the pharmacist. The pharmacist, consultant pharmacist or accredited pharmacist have to go through a very rigorous 2-year program to be accredited to provide HMRs. So once they receive this referral, they then make an appointment. They go to the patient's home so they can actually see everything that the patient is doing with their medications, including how are they storing their medications or how are they using their medications. They do at least an hour and a half's worth of interviewing, and then they come back, they check their literature references, and they make a report that they send back to the GP, as well as if they were not the regular pharmacist, to the patient's regular pharmacist. And for doing this, they're also allowed to follow-up visits. And in COVID, these were allowed to be teleconsults. And for doing this, they get paid about $222 for the initial HMR. Now, you might say, well, is there evidence? Do these work? What's the point of funding these? So a very recent systematic review, which collects all the data together, looked at the value of these HMRs and suggested that HMRs actually improve adherence to medications. They decrease inappropriate prescribing, hospitalizations, number of medications prescribed, and cost. So they are quite valuable in improving healthcare. Now, whilst the HMR is a very comprehensive, intensive kind of medication review, there's also funding in the latest agreement for something called MEDS checks. MEDS checks are very brief, on-the-spot medication checks that a pharmacist can do. For example, for diabetes, if people are on more than 5 medication, or they've just been prescribed, let's say insulin, and they need to know how to use it, you can do, as you're dispensing the medication, you can actually do an on-the-spot check. You can check whether the patient knows how to use the medications, whether they're using them appropriately, or whether they're adherent long-term. It's a very short 10 to 15 minutes. And you would say, how is it that, you achieve a standard of care? So actually our dispensing programs will prompt a pharmacist to tell them that a patient is eligible for a MEDS check, for a diabetes MEDS check, and they will also lead the pharmacist through a number of steps that are embedded in the program to make sure that we've consistently checked the right information and done all the right steps for a MEDS check. One of the more recent trends, I would say, is general practice pharmacists. So these are not, so we're moving on to the second quadrant. So general practice pharmacists are supported as a role by the Australian Medical Association and the Pharmaceutical Society, but they don't have a Medicare item number. But they can be funded through local health districts or local health area funding. And sometimes, as general practitioners and practices are realizing the value, many general practices, particularly the larger ones, are actually paying the pharmacist's salary out of their own funds. So a general practice pharmacist is a pharmacist that's working with the doctors in a general practice in the primary care setting. And their main job, of course, is to undertake medication review, educate patients, and also educate prescribers about new drugs or difficult drugs or other important information related to technical information related to drugs. And again, systematic review shows that they also can add value to healthcare provided in primary settings. So for example, You can identify medication-related problems, improve adherence, save money and time for the doctor. So the doctor doesn't have to sit and try and find the right information for a drug, and overall patient health outcomes. Now, I want to share with you a very recent study that was published in just this year. And this was a trial called the Remain Home trial. In this trial, which was a randomized controlled test, the researchers took people who were being discharged from 7 hospitals in Queensland, southeastern Queensland, and they took people who at the time of discharge had either 5 or more than 5 long-term medicines, or they had just been diagnosed with heart failure, or they had an exacerbation or a flare-up of their chronic obstructive pulmonary disease. And then as soon as the patient was discharged, a letter was sent to the partner general practice, and these were general practices which had a pharmacist. And within 7 days of discharge, the pharmacist had a consultation with the patient and went through their medications, showed them how to use their medicines, corrected if there were any mistakes between the hospital and the usual medicines a patient was using, etc. So this is just to show you that there were 177 patients in the control and 129 in the intervention group, roughly about 70 years of age, roughly with about 5 different chronic conditions. And so in the intervention groups, the researchers were able to show that there was a 54% statistically significant decrease in hospital presentations over the next 12 months after discharge, decrease in unplanned hospital readmissions, and also that the intervention, the benefit or saving from the intervention was about $5,000 per patient. And it's like 30 times more saving than what the cost of having a general practice pharmacist in these general practices was. And of course, pharmacists could identify medication-related problems, and GPs, when they had a suggestion from the pharmacist, in 80% of cases, they implemented the pharmacist's suggestions. Okay, then I'm going to talk about the third quadrant, which was entrepreneurial services. And this is just a cardiovascular type example, where one of my colleagues in Monash, in Victoria, another state, did an online web-based survey of all pharmacies, about 5,000. It did have a good response rate. So the response rate was only about 6%. So 294 pharmacies responded, mostly from cities. Mostly they were pharmacies that had either 1 or 2 pharmacists only, and they were open for 55 hours per week. But the important result was that when these pharmacies were asked, what kind of screening, cardiovascular health type screening do you do? 96% of them were measuring blood pressure. And only 8% were charging a fee from the patient. Because remember, this is not a funded service. This is just something a pharmacy is doing to get a competitive advantage. So very few were charging. They were also measuring cholesterol, point of care testing, and 24%, and they were charging for cholesterol measures, diabetes screening, 28%, and only a third were charging, and not charging too much, just like $5. And some pharmacies were doing multiple risk factor screening, about a fifth of the pharmacies, and 40% charge, and they charge the patient around $20. So let me show you some research now. So these are projects which have been funded either through the community pharmacy agreements or through other funding bodies. So this is a study called the PART CVD, so Pharmacist Assessment of Adherence, Risk, and Treatment in Cardiovascular Disease. Now this was a single group study. So you took in patients and you measured their objective cholesterol, blood pressure, blood glucose at baseline and then at the endpoint. So there were 10 pharmacies, and the idea was they would all invite 10 patients each. And at the baseline visit, pharmacists would do a very comprehensive risk assessment. So do a Framingham score where they would look at the absolute 5-year cardiovascular disease risk calculation, measure cholesterol, blood glucose, blood pressure, body mass index, waist to hip ratio, everything. And then they would actually organize a home medicine review for the patient. If they could do it themselves, very good. If not, they would get a consultant, and they would send the report of the HMR to the patient's GP, and they would see the patient 5 times, talk them through, you should cut down your smoking, let me help you. Here are some information. You can call Quitline, again, looking at diet, looking at exercise, and counseling about all of these risk factors. So in this, there were 67 patients who completed the study, and more of them were women, about 60 years in age. About 90% had been born in Australia. So what happened? When you compared some of these factors at baseline and at endpoint, it was very clear that even though this was only a pre-post study, but these were objective markers that were measured, that there was significant improvement in terms of the absolute 5-year cardiovascular disease risk, individualized cardiovascular disease risk. There was changes in blood pressure, there was changes in body weight, changes in the BMI, and also in the waist circumference. And if you looked at, okay, how did these changes happen? So like, why did blood pressure improve with the pharmacist intervention? It was clear that there was a big change in adherence to blood pressure or other cardiovascular medications. And patients also improved their diets. So you can see here in bold, it means it was statistically significant change. They changed the way that they ate saturated fats or salt, and also increased their physical activity. So it was very clear why some of those objective markers or risk factors actually improved. Okay, moving on to diabetes. So this was a screening study that was done by my own colleague, Professor Ines Kras, who led this study. So the pharmacy diabetes care program looked at screening for people who might have diabetes but were as yet undetected or undiagnosed. And the group compared 2 different methods of screening. So one method was looking only at a questionnaire or tick test, so tick, tick, tick. And the other method involved sequential screening. So just to show you here, so these were some of the risk factors that were in the questionnaire. So in one arm of the study, patients were just given this, and if they ticked more than one, they were referred to the doctor, the GP. In the other arm, if patients ticked more than one factor, they were immediately given capillary blood glucose test, fasting. And if the patient's BGL, fasting blood glucose, was more than or equal to 5.5 millimoles per liter, they were referred to the GP at once. If the patient wasn't, fasting, you did a random blood glucose test, and then if the answer was that the blood glucose levels were more than 11 millimoles per liter, they were referred to the GP for diagnosis and testing. And if it was between 5.5 and 11, they either tried to do a fasting test on another day or retested the patient after 2 hours, or simply because the answer was unclear, they sent the patient to the doctor. And again, just to show you, these were the 2 arms. There were 800 people in the questionnaire tick arm only, and there were 484 in the sequential screening arm. And they all had various levels of risk factors that were clearly going to increase the risk for diabetes. So here is what happened. In the tick test, there were 802 that we started with. 225 were referred. Now, not all of them actually, when the pharmacist said go and see the doctor, not all of them took up that referral. So only 127 out of 225 went to see a doctor, and 16 were diagnosed either with pre-diabetes or with diabetes. In the sequential screening arm, you started with 484, and the pharmacist referred 118, and 50 of these actually took up the referral, and about 18 were diagnosed either with pre-diabetes or diabetes. And overall, it seemed that the sequential screening arm, where you actually did a blood glucose test, was more cost effective because it was able to have more people take up the referral and more people diagnosed per screening done. So clearly, pharmacists have the ability to identify risk factor and triage people at risk with their regular doctor. And this means people might get an earlier diagnosis and early treatment compared to, having another few years going without being picked up as having diabetes. Pharmacists can also play a role when people already have diabetes. So this was a chronic disease management study called the Diabetes Medication Assistance Program. And this is a picture of one of the participants in the study. Now, in this particular research project, there were about 90 pharmacies that were recruited nationally across Australia, and they were given a very comprehensive training. They had to do an exam to pass as a DMAS pharmacist. And then they were all asked to recruit 10 patients each. And patients had to have a HbA1c level of more than 7 that had to be confirmed by the patient's doctor. And then at visit 1, patients were given a blood glucose monitor, and pharmacists did a baseline assessment of the patient's knowledge about diabetes, adherence to diabetes medications, medication-related problems, etc. And then they had 4 subsequent visits where really we were trying to encourage the patients to undertake self blood glucose monitoring, provide them with self-management support interventions, and have them set their own goals for what they want to achieve by the next visit. So again, this is just to show you that the patients who joined this study were about 62, 63 years old. There were roughly an equal number of males and females. They had had diabetes for about 10 years. And the most common comorbid condition was high blood pressure or high cholesterol. Okay, so what happened with the results? Now, of the 90 pharmacists, 83 actually continued to take part. They recruited 524 patients who initially joined the study and 387 that completed. Now, over the 6 months of the study, 18,000 self-management support interventions were delivered to the patients. 90% of patients set some sort of goals for themselves, and a third of the goals had been achieved by the end of the study. And the type of interventions that pharmacists provided were mainly around, adhere to your medications, monitor your blood glucose, change your lifestyle, and of course, sorting out any medication problems. And when the mean blood glucose levels were measured, there was a significant decrease between baseline and endpoint, which was a very good result. And patients' levels of adherence were improved, or non-adherence was decreased. And although not significant, the portion of people who were smoking also decreased, and those who took up exercise increased. And most patients were really happy with the service. They felt far more confident of managing their diabetes and making appropriate lifestyle changes. So overall, I've shown you a picture of different types of services that community pharmacists in Australia can provide, and the clinical and cost-related and humanistic benefits that are subsequent to pharmacist interventions. And in fact, in a very recent edition of the Medical Journal of Australia, so I realize many of you in the audience might be medical students, the editor has written a very, very firm piece saying the general practitioner and the pharmacist, we need to change the policy so that they can actually work together, because there are clear benefits when GPs and pharmacists collaborate and work together in the same setting. So I'm going to conclude, make some broad conclusions. So I would say that Australian community pharmacists are forging ways to enhance professional services using unique opportunities that might range from funded, supported research or commercial pathways. Pharmacy services have consumer support, and they show evidence of clinical and economic benefit. And so I think the takeaway message would be that in countries where there's a high level of non-communicable chronic disease burden, pharmacists represent an underutilized workforce, and some tasks in terms of patient management can be shifted from the medical workforce to the pharmacy workforce. And this shifting can allow for shared care, for better national health outcomes. And of course, I think what we need to do, given that we're talking in a university setting, is to look at more education. So look at interprofessional learning, perhaps getting people to study together and to undertake more research in the local setting. So of course, I have references if anyone wants to look, and I acknowledge all sources of graphic imagery that I have taken from the internet. And I think that's the end of my talk. Thank you very much for the privilege of being able to share my views about pharmacist roles today.
Thank you, Professor. It's a very valuable for the brief overview. Professor Saini, there is around 2 to 5 minutes for discussion session. Well, is there any question from our participant? If you have any question, please raise your hand. Please come on stage, Dr. Alberta.
Thank you for the opportunity. Good morning, Professor. I would like to ask the questions. How can you make sure the collaboration between GP and the pharmacist can improve the health conditions of these diabetic patients or the non-communicable disease for patient with non-communicable disease? Thank you, Professor.
That's a fabulous question. Thank you for asking it. I think the first thing starts at pre-registration. So at our university, not all the time, but we try to do some interprofessional learning where we give doctors, nurses, pharmacists, physiotherapists, dietitians are all together in the one classroom, and they're learning about the one, key chronic condition, so asthma or diabetes, and they solve the condition together. So they learn to appreciate the particular or specific skills and knowledge that each particular profession has. So that's one aspect. I think the other aspect is to do, if you're looking at the Indonesian context, it would be really important to do some local research. So till you can showcase to your policymakers and professional leaders in both professions that such models will work in the local context. So, general practice pharmacists are not unusual. For example, there's been GP pharmacists in UK, in Canada, in New Zealand, and in some types of services in America as well. But you have to test it in your local setting. Once you have some demonstration, pilot studies, and some data, then the next thing would be to talk at the policy level. So make sure that the leaders of the medical profession and the pharmacy profession talk to each other, ensure there's relevant training and credentialing for the pharmacists. And then there's also, it cannot work till there's local accommodation as well. And so in a research project I personally did about asthma, we also published it this year. We talked to GPs about what can pharmacists do for you in asthma. And they gave us a list of things that they would like pharmacists to do. But they also said, okay, to have a pharmacist, I need to make sure how I'm going to pay the pharmacist and where the pharmacist is going to sit and what is the logistic model, i.e. is the patient going to see the doctor first, then the pharmacist, or patients see the pharmacist first, then they go and see the doctor. So some of these issues have to be decided. Or can the pharmacist sit in the same room when the patient is seeing the doctor? But those decisions have to be done at each individual practice level. So I think you probably have to go through several of these steps, some simultaneously, and some will obviously have to be foundational step for it to work.
Okay, thank you.
I'm sorry, I hope I answered your question.
Thank you, Professor. Is there any question? Please come on stage.
Thank you for this occasion. Professor, I want to ask about how is the collaboration between general physician with other health participants, with other health professionals, in order to keeping an eye on patients' discipline for taking their drugs or therapy in Australia?
Okay, so you're asking about what happens in routine care, not just in situations where there is a general practice pharmacist. So I think we already have these mechanisms for ensuring appropriate medication use, which include the home medicines review or the residential medication management review. Then we have those diabetes meds checks that a pharmacist can already do. Most pharmacies, when they pick up a medication error that requires a GP or a doctor to change the medication, even if they're not working with the doctor, we just pick up the phone and we call the doctor and let the doctor know that we've seen this patient with such and such a problem. We would like you to please look at the patient's medications. So it is working, but often, there might be a delay. Like if you call the doctor's with the patient and you can't speak to the doctor directly. So you leave a message and, doctors are very busy people, whether they see the message or not, whether it works, is a question. The other thing you asked about collaboration between general practitioners and other healthcare professionals. So traditionally, we have had small general practices with maybe 4 or 5 GPs. And if a patient needed to see a podiatrist or a dietitian or a physiotherapist, they would be referred to the professional. And then the patient, would see the other professional, and the service can, in part at least, be billed to Medicare. Not all of it, but some of it. Increasingly, what we are finding is that because general practice is very costly, the insurance for each individual doctor costs a lot of money, and you need to have a lot of equipment, patient management, data management, cybersecurity, electronic health records. So now more and more general practices are becoming larger. And in these large mega practices, we often find that there might be a dietitian in the practice or a physiotherapist that comes to the practice 3 days a week. And in these practices, although not all practices have pharmacists, very few do, but very often there's a pharmacy close by that the GPs will have a good relationship with. So that's how it's currently working.
Okay, thank you for the question, for the answer, Professor.
My pleasure.
Thank you, Professor. There are 2 more questions, Professor. Please come on stage.
All right, first of all, I want to say thank you for this opportunity that I can attend this lecture. So my name is Salsa, and I want to ask about will the role of doctors be replaced by pharmacists later on as pharmacists keep developing? Thank you.
I'm so sorry. I couldn't hear the question. Maybe if you wouldn't mind repeating it, you've got the mic.
Okay. My question is, will the role of the doctors will be replaced by pharmacists later on as pharmacists keep developing? Thank you.
You've asked a very, very tricky question. A lot of doctors or general practitioners don't like the idea that pharmacists will take on these roles because they feel we as pharmacists are encroaching on their role boundaries. But I don't think that the role of a doctor can ever be replaced because pharmacists can only deal with medications. help the patient how to use the medications, help the doctor to prescribe them in a smarter way. But we can't diagnose a condition, we cannot prescribe. We don't really have prescribing rights except for minor ailments, for drugs that are over the counter, which we can provide. But for prescription drugs, we cannot give a prescription drug without a doctor's opinion and a valid prescription. So no, I don't think that the doctor's role can ever be replaced by pharmacists.
Okay, thank you for your answer.
It's a great question though.
Thank you, Professor. Now for the last question, please come on stage.
First of all, I will say thank you, Prof, for the lecture. Let me introduce myself first. My name is Elisa Desindi, and I'm on 3rd semester right now. And so the question that I want to ask is, what are the factors that influence the interprofessional collaboration process in home medicine reviews in Australia? Thank you, Prof.
So thank you so much for the question. I heard the first part, which was about factors that affect interprofessional collaboration. Again, there are different factors. I think the starting factor is the leaders of each profession. So you know how the leaders of the pharmacy profession and the medical profession and the medical society and the pharmaceutical society have to really have open dialogue. Sometimes it happens, but on some occasions it doesn't happen. An example is vaccination. So about 6-7 years ago, pharmacy did a demonstration project about providing flu vaccines to people. And the medical profession did not think that that was the right move. But actually, it's much easier to get a flu jab from a pharmacist because you don't have to make an appointment. Pharmacists are able to administer drugs. They're all trained in first aid. So over time, I think they came to an understanding that yes, pharmacists can actually do it. And in COVID-19, it was very clear that often, doctors' surgeries were closed. If there was a patient with COVID and an exposure, the surgery had to shut. Whereas pharmacies were businesses, so they managed to rotate their staff and keep open. So now I think pharmacists have played a major role in not just vaccinations in pharmacy, but also in vaccinating in healthcare centers. So even the students from my school have gone and helped after receiving training, of course. So I think that open dialogue between the top levels in the profession is very important. I think respect for each other is very important. So no one is taking over anyone's role, but we have complementary roles, and our shared vision is always going to be the benefit of the patient. So if we all start with that mindset, and part of that mindset has to happen if people are trained together at university. So then you can really appreciate each other's strengths. And the last factor is the local, if I'm working in a pharmacy, I have to show my professional respect for the doctor that I'm working with and vice versa. So some of those individual relationships can also make a big deal at a local level. If that doesn't answer your question, please feel free to let me know.
Okay, thank you, Prof, for your explanation. Thank you.
Okay, Professor, that's all for the discussion session.
Terima kasih.
Thank you so much, Professor, for your time and for joining us today. We got a very valuable information from you, and we hope we can still keep in touch for our maybe next or future scientific events. Thank you so much, Professor. Have a good day.
My pleasure. Thank you so much.
Terima kasih Profesor Seini atas presentasinya yang luar biasa. Para hadirin sekalian, tidak terasa waktu sudah menunjukkan siang hari. Sebelum kita masuk ke sesi presentasi poster, kita akan masuk ke sesi istirahat sampai jam 11.20. Untuk Bapak Ibu dimohon untuk makan dan minum di luar ruang teater. Untuk perwakilan dari puskesmas akan diarahkan ke ruangan sebelah untuk makan siang. Mohon maaf ada ralat. Istirahat sampai dengan jam 12.20. Terima kasih.